Well, I'll quickly begin again and say it is an honor to welcome and thank Dr. Anthony Fauci for accepting our invitation to address a Zoom audience today at the Dartmouth-Hitchcock Medical Center, and to briefly introduce him to our audience. I knew Tony many, many years ago when we were both studying and working at the then named New York Hospital Cornell Medical Center in New York City. I will introduce him very briefly because Dr. Fauci will be with us for only 30 minutes, and owing to his distinguished reputation as a physician scientist, the current coronavirus pandemic, and our contentious American politics, he is now famous both nationally and internationally. Since 1984, he's been the director of the National Institute of Allergy and Infectious Disease at the National Institutes of Health in Washington, and has advised every president since Ronald Reagan. Dr. Fauci is one of the most cited authors in scientific journals. He has been at the forefront of efforts to contend with viral diseases such as HIV, AIDS, SARS, the swine flu in 2009, MERS, Ebola, and the current COVID epidemic. Dr. Fauci has received well over 40 honorary degrees from colleges and universities here and abroad. In sum, a recent article in the New York Times cited him as a national treasure. Finally, an accomplishment of Tony that some of you may not know about. He was born and raised in Brooklyn when the Brooklyn Dodgers was at their apogee. And Dodger fans were fanatic. But Tony Fauci survived, even though he was a New York Yankees fan. I now pass the baton to Joanne Connolly, the president and CEO of the Dartmouth-Hitchcock Medical Center, and she will chair the remainder of this meeting.
Thank you, Dr. Strickler. You know what? I'm going to change the order up a little bit. Lisa, will you ask the first question?
I'd be pleased to. Dr. Fauci, such a privilege. You were at the forefront of addressing the frightening spread of HIV in the US and in the 1980s. Many of us recall there was a lot of anxiety at that time. So how would you say the public reaction to COVID differs from that? And are there any lessons to be learned?
Well, I think the lesson of similarity is that outbreaks occur. They've occurred long before we were around. They're occurring now, and they will continue to occur after we're all gone. It's just the nature of the interaction between the microbial world and our world of humans, particularly those that jump species, the way both HIV did from a chimp to a human, and how COVID did with a bat to whatever the intermediate host for this one is. We know from SARS it was a civet cat and a camel for MERS. But the thing that's different about it is that with HIV/AIDS, it was clear from the beginning that this was not a threat to the entire world's population. In fact, it was a selected demographic group, first thought to be restricted particularly to gay men, which it became clear very quickly that it was not. But there was stigma associated with either being at risk for or getting infected. It was gradual, insidious. People underplayed it. They didn't think it was particularly important. President Reagan, who I served under as my first president that I've had the opportunity to serve, didn't even mention the word HIV until his second term. So the world wasn't afraid of it, but they stigmatized people who were infected. Fast forward almost 40 years to COVID, and you have an explosive outbreak that wasn't subtle in any way, that has now gripped virtually everybody on the planet is afraid of this pandemic, rightly so, because it is historic in its proportion. So the similarity of a new infection being thrust upon society is quite analogous. Divergent greatly in the scope of it, the acuteness of it, and how it's gripped the planet. We didn't see the world shut down with HIV, but we're now seeing the world shut down with COVID.
Dr. Fauci, there were some behaviors, though, that I know people were focusing on changing the behaviors in order to keep people safe. We have the same challenge now with mask wearing, that it is a behavior that will actually improve safety for a broad swath of people. How do we actually help accelerate the public acceptance of wearing a mask?
Well, we're really faced with, I think, two components of that problem that are troublesome but tough to overcome. The first is that some young people, not all, but some, because of the extraordinary diversity of this range of clinical manifestations that's unlike any infectious disease I've ever dealt with, where you have 40% or more of the population completely have no symptoms. Some have mild symptoms. Some have symptoms that have to keep them in bed for a couple of weeks. Some get hospitalized. Some go on to intensive care. Some get ventilated, and some die. So depending upon where you are, if you're a young person who feels probably inappropriately that you're completely okay, you're not going to get into trouble, which is statistically is true. You won't get into trouble. You may not take this virus very seriously, and it really needs to be taken seriously. So wearing a mask, if you don't take the infection seriously, is a tough one to sell. It becomes even more tough when there's this political symbolism of, if you wear a mask, you're on this side of the political spectrum. If you don't wear a mask, you're on that side, which is completely crazy, because this is a disease, a virus, a public health issue, and not a political issue. And now we've kind of politicized masks, which is really unfortunate. And I think we're now getting away from it when we're starting to see some unanimity of message that we need to be wearing masks at all time, physical distancing, avoiding crowds, all the things that are so simple for us that we know scientifically would either blunt this surge that we're seeing or prevent future surges. And I think now, as we're moving on, more and more people are accepting that.
I'm going to ask Michael Calderwood to ask the next question, which is around reopening schools, et cetera. He has a series of questions that are nested one in the other. Michael?
Thank you, and thank you for the opportunity to ask these questions. You know, I think it plays into what we've been talking about, and this idea of what we need to do to safely reopen things like schools and colleges and business. My question is that different areas of the country are experiencing the impact of the virus differently, and decisions about policies are going to depend on local epidemiology. I wanted your thoughts on standardized national guidelines on when to reopen schools, colleges, businesses. How much of this has to be made kind of locally, and how much can be guided at a national level?
Well, that's a great question, Michael. I think that let's take schools as an example, and you could spin off everything else from schools. So you have to set certain fundamental principles and guidance and support at the national level, but the actual implementation and operationalizing of it has to come locally. The issue with schools is really important. So I would say that as a 40,000-foot default principle is that we should try to the best of our ability to open the schools for the following reasons. A, the detrimental effects on children who are kept out of school, psychologically and otherwise. And B, the downstream unintended ripple effects that go beyond the children and go to the parents who may need to interrupt their work to take care of the children who are no longer in school. That's a fundamental principle. We should try as best as possible to get the kids back to school. But there's a big however in that. And the however is paramount has to be the safety and the welfare and the health of the children and the teachers, and secondarily to the parents who are dealing with the children. So I think you started off your question perfect. We live in a big country, and we don't have a country that's unidimensional. There are different levels of infection in different parts of the country. I think to say every child has to go back to school is not really realizing the fact that we have such a diversity of viral activity. There may be some sections of the country where the viral activity is so low you don't have to do anything different. You could just send the children back to school. There are some areas where the level may be low, but not absent and maybe a little troublesome. You might want to modify the schedule, a hybrid, part online, part in person, morning, afternoon, alternating days, whatever it is that the local authorities. And that there may be some areas that the level of virus is so high that it would not be prudent to bring the children back to school. So you can't make one statement about bringing children back to school in this country. It depends on where you are, and we've got to be very flexible.
The follow-up to that actually plays off of what you were saying around making sure we're protecting both the students and the teachers. One question has come up around young children and their ability to comply with mask wear, and whether they'll be frequently touching and adjusting their mask, and that interaction with their face may actually increase the harm more so than the mask decreases the harm. And understanding that not all children will wear masks appropriately. Some may, as we've seen in the community, wear them with the nose exposed, etc. Do we want to think about asking teachers not just to wear a mask, but to do things like we do in the hospital, such as face shields or eye protection, to provide an additional layer of protection?
Well, I've spoken to a bunch of teachers groups, most recently the American Federation of Teachers, and that's what some teachers are actually doing, namely is putting, I got one here, something like this, you know, a typical face shield in addition to a mask. You know, I said that, it went viral after I said it. I got to be careful everything that I say. I'm not making a formal recommendation that everybody has to wear a face shield, but when teachers say, should I wear a face shield? Of course, because eyes are mucosal surfaces, and you might as well protect that if you want to. But the minimum, at least, you should be wearing a mask, at least. I mean, that's one of the 5 or 6 principles that we all should be doing.
Sounds good.
Perras, ask the next question. Joe is our CEO at Mount Ascutney and takes care of people in New Hampshire and Vermont, and we are the oldest people in the country. Joe?
That's right. Before I get to the question, Dr. Fauci, I'm sure you remember this as clear as I do, but we met 27 years ago in the lobby of Building 10 when I was on my way to David Margulies and Randy Robato's labs. You can imagine what that experience was like, especially with a character like Dr. Robato. But 2 summers with him was great. I'd much rather be talking about how we can maybe have some Red Sox prospects go to the Nationals in return for some pitching after watching the Red Sox start their season. But I wanted to talk a little bit about our demographics here in New Hampshire and Vermont. And it was my chief concern back in March, because Vermont and New Hampshire are 2 of the 3 oldest states in the Union. The other side of that coin is that Vermont and New Hampshire rank very highly as far as the fittest or healthiest populations in the state too. So I felt we were going to have this back and forth between the older demographic and the fitter demographic, and what would win out over time. The other, I think, contributor here is folks in Northern New England are pretty good at social distancing. It's, you know, we're good fences make good neighbors country up here. So it wasn't too much of a stretch, at least early on in the pandemic, to socially distance. But our question, or my question, is really around what we've seen, or what you've seen with vulnerabilities across the age spectrum and different syndromic presentations of the virus, depending on how old one is. And really, how does infectivity change over the age spectrum from the very young to the very old?
Yeah, you know, I think it's probably, first of all, we don't know precisely, but there's nothing that we've seen to make us think there's any major degree of difference in infectivity. In other words, in the likelihood that you'll get infected, if that's what you mean by infectivity. The issue that is been debated, but it's being clarified, and we really need to learn more about it. It's a very good question, particularly among children. So there's the Korean study that shows that children from 10 to 19 get infected and transmitted to adults as easily as adults transmitted to adults. In that same study, children younger than 10 were said to not get infected as much, or not necessarily get infected as much, but to not to transmit it as readily to adults as adults do. Then another study came out recently, which is really concerning, showing that children, particularly very young children, have anywhere from 10 to 100 times more virus in their nasopharynx than do older children. If that's the case, then there's no reason to assume that if you're having such a high viral load in your nasal pharynx, that you're not going to transmit it pretty easily. So I think we really need to sort that out. And in that regard, we started a study here at NIH, an extramural study. We're funding it outside of the NIH, of 6,000 people and 2,000 families of children. It's called HERO study for human epidemiology for coronavirus transmission. And what it's looking at is how often do kids get infected? Do they transmit it to adults? Do adults transmit it to them? And what's the clinical course and association with other conditions? So we're going to get that information, Joe, sometime in the next several months. But inherently, there's no reason to believe that a 30-year-old is more infective in transmitting than a 65, 70-year-old. There's no evidence at least that I've run across, that indicates that.
Our next question will be asked by Dr. Antonia Altomare, and it's about vaccines. Antonia?
So, Dr. Fauci, the Moderna and Pfizer vaccine trials are going into phase 3 right now, and there's hope that we'll have an answer for these trials by the end of the year. The question is, does that seem realistic? And then in follow-up to that, about a month or so ago, there was a survey that was done in the US that showed only about 50% of Americans were willing to get vaccinated. So what's your advice on how to perhaps encourage vaccination amongst our nation?
Okay, so Antonia, the first part of your question, it is realistic. I think that the speed that is being done is not at the compromise of safety, nor is the compromise of scientific integrity. It was really the fact of the technology, the example being, when you make a classic vaccine, even if you use molecular means, a few years ago, you would have to get the virus, grow it up in copious amounts, either attenuate it or inactivate it. That would take months and months and months. When we got the sequence from the Chinese, not just us, but everyone who's doing this, literally within days, vaccine development started. A phase 1 started in 62 days, and now we're in a phase 3. Usually the time from finding a new virus to going into a phase 1 is about a year and a half or more. We did it in 3 months. So that's where we save time. So I don't want people to feel that because it's going quickly, that you're sacrificing important components of the step-by-step process. You mentioned correctly, 2 vaccine candidates started phase 3 on July the 27th. We expect them to be fully enrolled with 30,000 people, 15,000 control, 15,000 experimental. Probably by 3 months of enrollment, we should get an answer by the end of the year, late fall, early winter. I'm cautiously optimistic. I'm a realist, but I'm also cautiously optimistic that even though you can't guarantee when you're dealing with vaccines that you're going to have an effective or safe vaccine, what we've seen in phase 1 studies is really encouraging. Namely, the people who were vaccinated with the moderate dose, 100 micrograms, were able to induce a response with neutralizing antibodies that was at least comparable to, and in some cases better and higher titer than what you see in convalescent plasma of people who recovered. And as you well know, as an infectious disease person, the hallmark of a vaccine is if you could induce a response that is as good as natural infection, that's a pretty good sign. Again, no guarantee, but that's a pretty good sign. So I think we're going to get there. With regard to your second question, we have a lot of work in front of us because we've got to outreach to the community. We've got to engage the community to understand that we're being very transparent about all the data and why it's so important to not only protect themselves, but for the good of society. It's not going to be an easy task because, as you know, there's a lot of anti-vax, anti-science feeling in this country that we've got to overcome.
Dr. Fauci, on the last question is about a phrase that actually was used by Dr. Deborah Bricks from the White House Coronavirus Task Force. She talked about us entering a new phase. So we've heard about the surge and the second wave. What does new phase mean? And what would it mean to the people that actually are attending this conference call today?
Well, what Dr. Birx was referring to is something that I totally agree with her on, in that right now, if you look at the southern states that got hit badly over the last several weeks, California, Arizona, Texas, Florida, what it was is that as they tried to open, sometimes a little bit too quickly, sometimes they opened correctly, but people didn't listen to what the authorities were saying. They gathered with no masks in crowded places, etc. What you have is community spread. And community spread is very insidious because by its definition, you rarely know where the index case is. You just see cases pop up. It's very difficult to do contact tracing because a substantial proportion of them are asymptomatic individuals who are inadvertently and innocently spreading it. So what she was referring to is that when you look at the cases now in the yellow states, red state greater than 10% test positive, yellow 5 to 10% test positive, green less than 5. It's those that are now at that level. When you look at a slight increase of a fraction of a percent or 1%, like you go from maybe 5.5 to 6.5%, that is a predictor that you're going to get an outbreak. And the outbreak is really at the community level. It's not talking about nursing home outbreaks, which is confined, you know what it is. Prison outbreaks, confined, you know what it is. This is this insidious, diffuse community spread that is very concerning because it's very difficult to get your arms around that unless you've practiced very, very carefully 5 or 6 fundamental things: universal and proper wearing of mask, avoiding crowds, physical distance 6 feet or more, stay away from bars and congregating places, and in some places the bars should even be closed. Outdoor, always better than indoor, whatever you do, and washing hands and hand hygiene. Those are 6 things that are easy to do. And what she and I and others on the task force have been saying, everybody should be seriously looking at that and doing that.
So as an anesthesiologist, it's interesting. Antonia and Michael have taught me a lot about infectious disease, and it sounds like it's almost you have to resort to mitigation strategies rather than containment strategies.
It's very difficult to do classic identification, isolation, and contact tracing when you have community spread that's diffuse. It's very difficult to do that superimposed on the fact that up to 40% of people don't have any symptoms at all. It's very difficult.
Well, we want to thank you so much for your time. You are actually a rock star here in New Hampshire and Vermont. We have many Fauci 2020 signs lining the roads around here. You are really the resource for us as we try to stay in the green zone, as New Hampshire and Vermont currently are. And I want to thank you so much for your time, your advice, and your leadership.
Well, thank you very much for having me. It's a pleasure to be with you, and I appreciate you giving me the opportunity to speak to your folks. Thank you.
Thank you. Now we're going to turn to our panel, and we have many other questions that were submitted by the audience. Why don't I give Michael the first question? One of our listeners was diagnosed as having H1N1 almost a decade ago and was admitted to the hospital with breathing difficulties, but was able to be treated at home with a nebulizer and albuterol. They've recovered after 2 weeks, but now they have this persistent viral-induced asthma. Are these the type of sequelae that we're going to see with COVID-19 as it makes its way through our community, Michael?
So this is a really interesting question. I think the first point to this is that we're really only entering our 8th month of really beginning to understand this novel illness, and some of the long-term complications we're only beginning to see. And as the year plays out, we will probably get more papers on some of these and even others. We definitely are seeing long-term things. Many people are reporting prolonged fatigue, headaches, muscle aches. Individuals who developed pneumonia as part of their initial illness are seeing some lung scarring and some longer-term breathing difficulties. Obviously, people that were hospitalized can be very deconditioned, and that takes a while to recover from. You know, the other thing that we are seeing is that there's inflammation of the heart itself and pericarditis from the virus. And so some people are seeing some long-term effects from that, whether that be heart palpitations, again, fatigue related to the heart recovering. But there are a lot of things we still don't know. What I'd say is there are definitely long-term complications.
And the next question is for Antonia, and then with a follow-up from Lisa. And Antonia, this is about colleges. And this was like on the front page of every single newspaper across the country, I think, today, and continues to be a hot topic. They are going to come into dorms and classrooms when the schools open in August. And there's really no consistency across the country about how to do this. From an epidemiologic and an infectious disease perspective, how do you think colleges should be approaching this nationally? And if you were the czar of returning to school, what would your recommendations be? And then I'm going to have Lisa follow up, and she's on the task force at the college to really talk about the things that they took into consideration before they made their decision. So Antonia?
Yeah, so I think this is a really difficult situation. And, you know, when this started, the reflex was to shut everything down because we didn't know what was going to happen and how this was going to play out. And now that we know, I want to echo Dr. Fauci in saying we have kind of some basic pillars that we understand to be very effective in preventing ongoing disease. And that is the social distancing, the wearing of the mask, the hand hygiene, the not going to school or work if you happen to be a professor or a teacher if you are ill. And then, of course, you can't anticipate those that potentially are infected without symptoms. And I do think, thinking about our nation and even down to the state level, the epidemiology is very different no matter where you look. So to make a standard recommendation that nobody should go to college is somewhat unnecessary and does come with the consequences of not going to college, not going to school. And so I think each individual state and region really needs to come up with kind of a risk stratified approach of what going back is going to look like, what precautions are going to be in place, what are the triggers to really step back and either start a hybrid, virtual, in-person, or all hybrid, depending on the situation. And I think it's going to take a lot of close eye on the case counts for that area. And it's going to be difficult, and I know Lisa will probably touch on this, when you draw from other parts of the states, other parts of the country, other parts of the world where people are coming in to go to college and then cohabitate together. That just brings in a whole bunch of other variables that can be pretty risky.
Lisa, do you want to comment on, you know, at a high level, how you came to your decisions at the college?
Sure, happy to share some of our thinking. So completely agree with everything that Antonia said, and I will say at Dartmouth, we began by following the local and national data very closely and really designing our reopening plan to be able to welcome back the graduate and professional students, and then about half of our undergraduate student body who will be living in on-campus residences. And we did this by having a plan that includes robust initial testing and an arrival quarantine period to identify quickly and early anyone who might have either symptomatic or this 40% of asymptomatic infection. We're also going to include ongoing disease surveillance during the term using testing and in partnership with Dartmouth-Hitchcock wastewater assessments. And then of course the required adherence to all the standard practices that both Dr. Fauci and Antonia mentioned. And I will say also many of our, but not all of our courses are still going to be offered remotely. I will also add that we are in frequent consultation with both internal and external experts, as well as many of our peer institutions, including those in locations similar to ours, because as Dr. Fauci mentioned, that is so critical to think about your local environment. So we're sharing our approaches, we're developing what we hope will become best practices. So I have to say, while this is new territory for all of us, we at least feel confident that we can develop a plan that will allow us to safely reopen in the fall.
So Lisa, there's also a follow-up question, and as I think about it, it's not a bad question. Have we ever thought about swabbing phones, cell phones, since people spend so much time with their cell phone around their face, and to actually see if we can determine a prevalence of COVID-19 on phones? They are supposed to be filthy.
And I believe that to be true. So I will say that's an interesting approach. And I know in dealing with this pandemic, responding to this pandemic, we need to be thinking outside of the box. So a response like that certainly wins in that category. But I do think if we're going to take a sample of something, why not let it be the human? We know that the virus has been found and can survive on various surfaces for hours up to days, but clearly the main mode of transmission is person to person. So I would rather focus on developing rapid, non-invasive swab or saliva tests that can be done maybe as home test kits that would allow rapid detection. As when I think about it, I'm not sure what we would do with the positive swabs taken from cell phones, except maybe test the owner. So why not go to the source at the start?
Yep, good point. Antonia, can you tell us a little bit about the difference in the vaccines? Because they're not all the same that are being produced.
Yeah, so there are over 165 vaccines currently in development locally, globally, but there's only about 27 right now in human trials in various stages. So as you heard, there's 2 right now in the US that are entering phase 3. And that's really the phase where we're going to start to see, does this vaccine actually really work? So it went through the phases of safety and immunogenicity of efficacy. But really, when we're talking about phase 3, we're talking about studying it in a population and seeing how many people really get infected. So right now, there's about 4 categories of vaccines out there, all again in various stages. And some of them are reminiscent of vaccines we already use. And some, in fact, use viruses that we already know about. For instance, there's a viral vector vaccine, which essentially uses a known virus, and the most common virus that uses is adenovirus, to actually deliver the genetic components of coronavirus into the cells to provoke an immune response. Aside from that, there's a genetic vaccine, which really just takes the genes from the coronavirus, introduces it to a human in order to provoke, again, that immune response, those antibodies that will eventually protect it against repeat exposure or repeat infection. Then we have protein-based vaccines, and these use just proteins from the coronavirus, either a part of the protein or a whole protein, again, to produce that immune response. And finally, less often used is the whole virus vaccines, and that's when you take the actual virus, you inactivate it or weaken it in a way and introduce live, essentially what we call live virus, into the human in order to provoke immune response. So we have vaccines, again, in all of these categories in several different stages being studied now, and I'm not sure which one will come out on top, but it sounds like we will know much more information, hopefully over the next several months, on efficacy and kind of what we are going to be looking at for vaccines coming in 2021.
Great. So Joe, as the head of a really a large community organization. What's your confidence that once a vaccine is identified, the people in your community will line up to actually get vaccinated on a scale of 1 to 10?
Yeah, that's a concerning question, certainly. The context is that Vermont and New Hampshire have rather strong vaccination rates at baseline. So that's a good sign. And our pediatricians are excellent public ambassadors for, at least early childhood vaccination. But it's a concern. Anyone that spent time on social media and has headed down the rabbit hole of conspiracy theories that exist there, it would make you nervous when you look at what's out there. That said, there was a great article in the last few days in the New Yorker by Bill McKibben talking about how Vermont has responded well to the pandemic thus far. And I put our neck of the woods in New Hampshire in the same camp there. And it's because of, active citizens that actually care for each other as neighbors, as coworkers. And I think we will see that benefit us when a vaccine does become available. But we will have some headwinds. And again, social media can amplify those headwinds as we move forward.
Yeah, I think you can look at the success of our flu shot program. I mean, thousands and thousands of people line up at our facilities to receive free flu shots, and they take it actually very seriously. So my
that's
expectation.
a good point. Yeah. We are trying to rethink how we do our typical flu vax clinics in the setting of social distancing, masking, and the need to keep our patients safe. So it's going to look a lot different this year, I think, for a lot of our flu clinics, and that's out of necessity. New Hampshire has been wonderful in getting their kids vaccinated for influenza in schools. That's something that Vermont has not done. So we're going to look to the New Hampshire model to see what we can do with our local schools to at least take that off the table for kids and parents in that setting. But typically it's the way you described it, lines out the door waiting for their flu shot. And that's something we're going to have to work around.
So Lisa, even if we get a vaccine, there are probably some things in life that won't necessarily return back to normal, and certainly not right away. What are your thoughts on that?
Oh, it's a great question. I certainly think it's fair to say that we all can acknowledge that life will be different, even when we are on the other side of this pandemic. I'm thinking specifically about things like our use of video platforms for telehealth, for remote learning, and for flexible work schedules, and then perhaps the frequency with which we travel. And those are some of the ways in which I think we may do things differently. And I'm sure all of us have thoughts and ideas about how this pandemic has or will affect our individual lives. And I guess I would just say, I hope that we can all find ways in which it will be for the better. I also really hope that this moment serves as an important call to action to strengthen our public health systems at all levels. I would say this is the most intensive pandemic we've experienced to date, but it's not going to be our last.
So I just got a question from our viewers that asks, as CEO of one of the largest employers, what do you think leaders can do to encourage mask wearing? I actually do believe that we need to have a public campaign about mask wearing. That, as Dr. Fauci pointed out, this is not political, it's a public health need. And if we really care about the people that we work with and interact with, we'll put on a mask and really attend to social distancing. I think we all know or have young nieces or nephews or kids that think it can't affect them, but we know that this can affect everybody in our communities. And if we want to keep our communities safe, and I'm so proud of the really low infection rate level that we have, not only in the Upper Valley in Grafton County and Sullivan County, but really the northern part of the state. And it's because people take their community commitment seriously. And I think leaders need to really set an example for everybody in the community. Michael, there are a number of questions that we received about treatments. You know, in the beginning, we didn't really know what treatments were effective, but we are starting to identify what treatments may actually decrease the mortality with COVID. What are the things that you've observed as you have kind of led our response to this over the last 5 months?
You know, there was an interesting comment made on social media over the weekend by a resident that I thought was really quite nice. And it was someone that was talking about how humbling it was that early on in the epidemic, we were pushing one set of treatments that as we got more and more data, we learned didn't work so well. And now things early on that we said not to do, we're beginning to do. And this really does speak to the fact that we continue to learn how best to treat this illness. And for not just our trainees, but all of us, it is really humbling to realize that there are things that we know and there are things that we don't know. I think that right now we have gotten some good trial data on the efficacy of remdesivir. It appears that it's much better when given earlier in the course of the illness, and a lot of debate about how useful it is when someone is severely ill. We now are moving much more towards the use of steroids, particularly in individuals requiring oxygen and mechanical ventilation, but some early on really worried about steroids and had pushed back on that before we got this data. There are other newer antivirals that are being looked at both in this country and elsewhere. Favipiravir is another one that people are looking at. Hydroxychloroquine is one that we do not use anymore. I think the data really have come out against that drug. There are ongoing trials of drugs such as lenzilimab, mesenchymal stem cells are two we're looking at here at Dartmouth-Hitchcock, but there are other immune modulators trying to ramp down some of the cytokine storm that can lead to severe illness. And then obviously convalescent plasma is another thing that's been used, taking some of the immune serum from folks who have recovered and understanding where that is best used is still something that is being explored.
So Joe, as a community leader, I bet you receive a lot of free advice for leading in this crisis. What are some of the helpful hints that you've received from people in the community?
So surprisingly, actually not surprisingly, knowing my community, there hasn't been a real groundswell of advice coming in. It was more just questioning around what we should do, what we should not do. I think some of the things we hear at the national level have been echoed locally, and that's been around testing. It's been, should we be testing more? Should we be testing less? Do we just have rising cases nationally because we're testing more than other countries? And we certainly try to push back on those theories when we can. I think the worst rationalization that I've heard around the reason why folks get COVID was from the Texas representative who said his mask got coated with the virus and he just breathed it in and he blamed his mask for his virus. So I have heard some variations of that theme locally. Is my mask causing more harm than good? And I do refer folks to the many YouTube videos out there that show folks wearing masks, wearing multiple masks, and their oxygen saturation staying exactly what it has been despite wearing 2, 3, 4, or even 5 surgical masks. So there hasn't been really one terrible suggestion, but we've been just trying to stay on message, especially regarding masking and the benefits of wearing one.
Yeah. So Lisa, there is a lot of, originally there was a lot of misinformation about masks. And I think all of us know what PPE means. None of us knew what PPE, personal protective equipment, actually meant 5 months ago, but we all know about it. It's part of our language now. But this is our third pandemic. You would have thought that we would have figured out the mask thing already, like what's the most effective mask and what's the most effective way to wear it. how do you actually answer that question when somebody said, you should have figured this out already?
Well, it's a very interesting thought, but I actually think that we never really had to consider so seriously the importance of masks or face coverings and how to incorporate their widespread use into our daily routines, since we were always able to contain the prior epidemics without the kind of widespread face covering use that we're seeing today. But certainly, at this point, we have the start of a very good base of robust research for the utility of masks now. And so this will help us moving forward. But I think they just didn't play as critical a role in the prior epidemics that the research interest and funding, et cetera, wasn't there. But it is there now, and we have a lot of good information to guide us on how to most appropriately develop or create and use masks.
Great. So the next question is for Joe and Michael, and it's about actually moving patients. Remember when the New York City hospitals kind of got overwhelmed, there was a question whether or not some of those patients wouldn't be moved to hospitals that had capacity in the northern part of the state. And I think people regionally say, should we move people that are affected with COVID-19 to where the beds are, rather than trying to increase the capacity where the patients are? And I think there was a question around helicoptering patients in, and Antonia, I don't know if you want to weigh in, because we did spend a lot of time thinking about DART, our air ambulance, and try to make sure that we kept those crews safe when they didn't always know who they were transporting. So who wants to take a stab at that first, moving patients and the complexity of that?
Well, let me jump in just on some of the logistics issues on where you put patients in a situation like this. Both New Hampshire and Vermont state leadership tried to set up these ancillary hospitals and parking lots and civic centers, and they were largely underutilized or not utilized at all. I think most hospital leaders would much rather do a surge capacity at their own institution where all the nurses are, all the doctors are, all the support staff is, rather than trying to staff another ancillary hospital somewhere across town. And I think the state leadership has realized that we would much rather keep it, expand our own internal capacity and deal with folks at our own campuses. I'll speak from the system perspective. We kind of built it as we were flying it. Dartmouth-Hitchcock, wildly expanded its ICU capacity, so we all breathed a sigh of relief. Really, all the hospitals in New Hampshire and Vermont breathed a sigh of relief because UVM and DHMC increased their capacity. So we felt that we could deal with lower acuity patients and get the sick folks off to DH. And then we had to work as a system to determine where do those folks go after they're recovered? Where are they going to get their post-acute care? And we identified institutions within the system that could do that as well. So we, in our own neck of the woods, were able to coordinate that. But we still dealt with significant transportation issues in moving people just up and down 91 and 89. And I'll leave the ID-related issues to Michael and Antonia to address.
Yeah, this has been an ongoing discussion, and one that we've both planned for and then learned from some of the areas like New York and Boston who've dealt with this before us. And so, we did have times where some of the hospitals down in Manchester were reaching capacity and had need for assistance in terms of ventilator or renal replacement devices, and we were able to share some of that to support the care that they were providing. It is not easy to move some of these patients, particularly when they get severely ill. Some of these patients require multiple providers, particularly if they're involved in proning. It's not something you can easily move someone with a helicopter. It often requires an ambulance. And throughout this entire thing, we've really thought carefully about how do we protect the healthcare providers tasked with caring for these patients. And so any of these transports, we really need to think about, can we do it safely, both for the patient and for the people that were asking to do that transportation. In New York City, this came up a lot, and a lot of the hospitals in upstate New York were saying, we can take the patients, and oftentimes the hospitals in New York City said, we'd much rather have you help us by sending people to staff some of our surged ICUs rather than trying to move patients all around the state. So this is an ongoing discussion, but that at least was the experience in New York.
I can add just by experience from our Ebola and onward is that we had as a group and with DART in mind and comprehensively discussed these protocols with them, that it would not be possible physically to transport someone with a high threat infection via air, because there's no way to isolate off the driver of that cabin. So in the air, in a helicopter, there's no way to put that pilot in PPE that would protect them. And in addition, like Michael said, there are lots of equipment and people that need to go with the patient that just wouldn't fit. Additionally, there are sometimes state regulations about transporting a patient with a highly infectious disease across state lines. So that becomes also kind of a regulatory issue and requires a lot of co-coordination between state health departments. So in the end, we can offer everything we have, but more often than not, we're actually sending equipment and sending people to the area in need rather than the patients being moved.
I have a final question for Dr. Strickler. So Dr. Strickler, you've been a leader in infection control and working in really new kind of situations in developing countries for years after you completed your tenure as dean. What's the greatest advancement that you have seen in your career around the prevention of disease spread, be it HIV, coronavirus, MERS, H1N1? What's been the most important innovation that you've observed?
I think the progressive acceptance of public health across the world is the most important of all. Most of us who were born and raised as academic internists had to learn that the hard way. And I learned that the hard way in refugee camps all over the world, where patients were dying like flies because of inadequate nutrition, water that wasn't safe, day by day contacts, etc. So I think we have to continue to push hard on public health issues, in addition to the definitive inpatient kind of care that most of us were baptized on with.
Well, that's great words to end our session. I want to thank you, Dr. Strickler, for making it possible for us to invite Dr. Fauci to our noontime conversation. Lisa, thank you for your work not only at the college, but certainly on the task force for the college. It's an important step forward to bring the graduate students and certainly the undergraduate students back. Michael and Antonia, of course, for 5 months of relentless engagement and keeping the organization safe. And Joe, for actually leading one of the communities that made it possible for us to really care for our COVID-19 patients after they didn't need hospitalization here at DH. And I want to thank our entire audience for dedicating the hour with us. And I hope that all of you stay safe, wear your mask, social distance, hug your family and friends, as long as they're in your close-knit family pod, and enjoy the rest of the afternoon. Thank you.
Thank you.